Let's start new group of disorder, obstructive lung disorders. In obstructive lung disorder, these are the main four category here: the COPD, asthma, bronchiectasis, and bronchiolitis. We focus on the COPD versus COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disorder is a chronic disorder, and this disorder having the two groups here inside this disorder, two diseases together. The this disease affecting the bronchi, and it's an emphysema at the level of alveoli. Emphysema at the level of alveoli. So this disease affecting bronchi plus alveoli together, and emphysema or and bronchitis together is known as COPD. The COPD, this person having history of smoking. History of this person having history of smoking. A strong history of smoking. And next disease here is smoking. The smoke chemical, you can see here, the smoke chemical causing inflammation to bronchi, and the start injury process inside the alveoli is lead to emphysema. And next disease here, asthma. This asthma, the most cases of asthma, 90 to 95% cases are related with the allergy. The person is hypersensitive to anything, food, dust, smoke. The start the airway issue there is asthma. 90% are 95% the issue. The patient having allergic conditions there. Patient having allergic conditions there. And this asthma may be in non-allergic category, maybe non-allergic. Later we talk about in detail the different types of asthma and what are the allergic and non-allergic types there. Asthma is also what happened in this disease is in this disease hyperactive airway. Hyperactive airway is the main issue here. The airway undergo attack of constriction. Sudden bronchoconstriction start. The very active airway after entry of the allergen, the airway undergo constriction, and it affect with issue with the breathing now. Like bronchiectasis. Now, what's this disease? This disease having the focus on term is a bronchi word as a bronchiectasis. It's a bronchiectasis. And the bronchiectasis means dilation. This disease is known as permanent dilation. What's the cause for this disease? The problem here is the infection. The permanent infection, the chronic infection. This infection due to two reasons, and sometimes what happened, the mucus production there, the mucus production. If this mucus is not cleared, your duty to make it clear, like take this mucus outside, the cilia performing this function to take out this mucus. If you have the issue with cilia, is not working, it can lead to bronchiectasis. For example, the syndrome here, the syndrome known as Cartagena syndrome. In Cartagena syndrome, what's wrong here? The Cartagena syndrome, it lead to the problem, the issue here, the cilia, it lead to bronchiectasis. And the bronchiectasis may be, okay, one thing, the mucus is produced but not cleared. And the second thing, the mucus is very thick mucus, hard to clear. Very thick mucus, hard to clear. For example, the disease condition cystic fibrosis. In cystic fibrosis, the issue with the mucus is very thick, very hard to clear. So bacteria enter your lung by the air, stay inside the mucus, and easily to cause infection there. And that infection become permanent, chronic infection. This bronchiectasis due to chronic permanent infection. Okay, it's an infective issue. It's a permanent dilation of bronchiectasis followed by chronic infection. That's the issue in the bronchiectasis. Every disease here having some typical features. For example, if we talk about the COPD, this person having, because this person is a smoker, morning cough. or it's a person having morning morning cough, and this person, the the asthma patient, sympathetic system, parasympathetic system is excited at night too much. This person may have paroxysmal nocturnal dyspnea attack, paroxysmal nocturnal dyspnea, and this person having the chest, the feature of the asthma, chest tightness, paroxysmal nocturnal dyspnea, and the sputum produced in the asthma very scanty sputum. Scanty means also very little quantity sputum there, and very thick sputum in this case. The bronchiectasis is an infection. The bronchiectasis, due to infection, the sputum is foul smell. The foul smelling sputum there, very bad smell sputum. We can write here a bit space here. The bronchiectasis, the sputum having very bad smell, foul smell sputum, and sputum is too big quantity, very large quantity sputum, large quantity. Oh, the quantity is too much, quantity too much, and it's a bronchiectasis feature. The very large quantity sputum, and that sputum also having the foul smell, very bad smell sputum is coming out. That's about bronchiectasis, the typical feature of the bronchiectasis. Okay, now move on bronchiolitis. What's bronchiolitis? This disease is a viral infection. It's disease due to viral infection. The viral infection in children. The respiratory syncytial virus RSV. Respiratory syncytial virus, the more chances to causing the infection a bit deep in lungs at the level of bronchiole. So this disease in children is still affecting airway, respiratory syncytial virus. Okay, now move on. After patient having obstructive lung disorder, what's going on with the inspiration and expiration? What happened to expiration and inspiration? Here in obstructive lung disorder, expiration is the main issue. So okay, if you not expire the air from the lung, what happened with the CO2 concentration? The CO2 inside the body, because you're not going to expire, tissue producing CO2, and this CO2 must expire by the lung. In obstructive lung disorder, the issue with expiration, must keep in mind, it's very important typical feature for obstructive lung disorder. The person having the difficulty in expiration. So when expiration is affected, what happens? High level of CO2 is known as hypercapnia. The high level of CO2. When high level of CO2 there, it can increase the level of the acidic content inside the blood. It lead to acidosis because CO2 is the acidic oxide. It lead as respiratory acidosis there. Respiratory. Okay, one thing expiration issue there. Due to expiration, the more accumulation of the CO2 inside the body, it lead to acidosis. That's a respiratory acidosis. It's obstructive lung disorder, the main issue. Okay, what next happen? If we focus about the spirometry, what we can observe in spirometry? The spirometry, we can check the different volumes and capacity. In spirometry, we can see the total lung capacity is increased. The total lung capacity is increased. The total lung capacity is increased on spirometry. On spirometry, the functional, the residual force expiratory reserve volume for the force. Another thing here, force expiratory volume. The force expiratory volume is decreased. The expiratory volume is decreased. The force expiratory volume is decreased. It means this person having the main issue with the expiration. If we see the ratio of for example, the ratio of expiratory volume, the ratio with the TLC, the vital capacity if divided with the TLC, total lung capacity. What happened here? The total lung capacity is like how we measure total lung capacity after taking the full breath. The full lung now having the air, that's the total lung capacity. In total lung capacity, we having tidal volume, we having inspiratory reserve volume, we having residual volume. So all volume, the summary, the sum of force expiratory volume, the all volume inside total lung capacity. The vital capacity we can check the person first inhale air, then forcefully expire the full air. This vital capacity, the force vital capacity, the force vital capacity is decreasing here, and the TLC is increasing here, because with the every breath, the issue with expiration, the air go inside but is not coming out. If not coming out, this vital capacity, force vital capacity, and the ratio with the total lung capacity. So this is a force vital capacity. We having this the force expiratory volume inside this force vital capacity, the same thing. Okay, the ratio of force vital capacity and total lung capacity, the ratio, if you increase this and decreasing this, the answer of this ratio must be high. The ratio between these two can be its ratio is increasing. The ratio is increasing. That's a typical feature of this obstructive lung disorder. The ratio with the force, this force vital capacity, as a force vital capacity, it depends upon is also we need here expiratory force, expiratory volume. Force expiratory volume. If we divide, it's the same thing. If we divide with the total lung capacity, the total lung capacity increasing and these two things are decreasing. So what happened with the ratio? The ratio between them is increasing. That's a typical feature. Is a clinical finding for obstructive lung disorder. Is a spirometry for obstructive lung disorder. In obstructive lung disorder, the expiration was the issue. Expiration lead to hypercapnia, and the spirometry we can check the force, the total lung capacity, and total lung capacity is increasing. And if we move on COPD, what happened to the chest shape in COPD? The chest shape in COPD become barrel shape. Chest become barrel shape chest. Why chest become barrel shape? Because with every breath, how much air is going inside the lung, how much air is going inside the lung? 500 ml air we take inside, that's the tidal volume. So when the 500 air going inside, how much we can expire? Okay, you must expire 500, but the problem here, expiration is the issue here. So if expiration issue here, I just expiring for, I just take example, I just expiring for 50, I just expiring for 20, I just expiring for 100. So with each breath, you can see here, I take air inside the during every breath, the air going inside the 500 ml, but the air coming must be 500. But now what happened here now after obstructive lung disorder, the air coming out is less than the air going inside. So with the remaining air, with the each breathing cycle, expiration, inspiration, the residual volume, the inside the residual volume, the volume stains the lung after the breathing, that volume is increasing. The air trap inside the chest and air is increasing. The continuously expansion of lung due to retention of the air, excessive air retained. And that's why due to excessive retention of air, the shape of chest is a chronic disease. Okay, shape of chest changes to barrel shape. So the barrel shape, anterior posterior diameter, transverse diameter become nearly equal. Normally anterior posterior diameter is less than the transverse diameter. Now the both diameter become equal and the shape of chest look like as a barrel shape. It's like a barrel shape. This is about introduction of the obstructive lung disorder. The must keep in mind, main thing must keep in mind here, the affecting expiration and the ratio is very important. Spirometry, this ratio is increasing. So from here we can assess the patient having obstructive issue or restrictive issue. This spirometry is a bit different in restrictive lung disorder. Literally in the restrictive lung disorder topic we will talk about spirometry, what happens to spirometry in restrictive lung disorder. And what's the causative agents here? We again try to summarize it. For the COPD present in smoker, smoking is the issue here, And the asthma, the allergy condition, the bronchiectasis, the issue here, the infection, and the bronchiolitis is a viral infection. So viral infection is a chronic bacterial infection. It leads to bronchiectasis. And the asthma related with the allergy. This is all related with the obstructive lung disorder. Later we talk in the next coming lecture. We talk about in detail about the COPD, asthma, and bronchiectasis.